Welcome to today's Natera webinar, a ctDNA assay for remote monitoring and risk stratification for CRC patients, the new normal during the COVID-19 crisis. My name is Bob Hanson and I'm today's moderator. Some housekeeping notes quickly. Today's webinar is being recorded and you can ask questions at any time during the presentation by typing in the questions panel in our GoToWebinar interface and clicking submit. Today's presenter is Dr. Alexey Aleshin. He is Senior Medical Director, Oncology at Natera. Without further ado, let's get started. Go ahead, sir.
Thank you, Bob, for that introduction, and thank you, everyone, for taking the time to join us for this webinar. Today, we really wanted to address a few topics, including the cancer care that's being delivered in times of the COVID-19 pandemic, how treatment paradigms are changing and how oncologists are adapting to this new normal. We also wanted an overview of the Signatera residual disease assay, describing its performance and some of its use cases during this pandemic. We also wanted to review a few case studies about how some of our oncology collaborators have been using Signatera during this time. And lastly, we wanted to introduce our Signatera GI Expanded Access Program, where really the goal is to make the assay as broadly available as possible during this time. And lastly, we wanted to review how Signatera can be ordered remotely, as well as how it can be drawn remotely using mobile phlebotomy. So as I think everyone is aware on this call, COVID-19 has really changed how cancer care is being delivered, not just in the U.S., but all across the world. Multiple studies and publications have really shown that patients with cancer have poor outcomes if infected with COVID-19, with morbidity and mortality rates approximating those of patients with other severe comorbidities. And really, the limitations to cancer care access has been a major concern during this COVID-19 pandemic. CT scans and PET scans that are usually reserved for treatment of patients with cancer have been diverted towards supporting frontline care of patients with this virus. And really, this has not gone unnoticed. Multiple professional societies, including ASCO as well as the NCCN, have really worked very tirelessly to devise and release new guidelines for both surveillance as well as risk stratification of patients with cancer during this outbreak. And really the utility of MRD testing, or minimal residual disease testing during this outbreak, is to really better understand patients who are at high risk versus low risk for both having residual disease after definitive treatment, as well as at high risk for recurrence during the period of surveillance. That utilizes a simple blood test without needing to use traditional methods like imaging, as well as clinical or physical exam. And really, Signatera has the opportunity to remotely identify patients, even without having to go into the office, with either recurrent disease or patients who may be MRD negative, who may be eligible for reduction or delay in their chemotherapy or other types of visits. So let's first of all review the Signatera residual disease test. Just a very quick introduction to Natera. Natera is a company based in San Carlos, California. It's a company of over 1,000 individuals, with really the mission being bringing cell-free DNA testing to patients both in the U.S. and worldwide. We have three major core business units. One of them is reproductive health, where our assay Panorama is one of the most widely used NIPT assays for detecting non-invasively fetal chromosomal abnormalities in expectant mothers. And we've recently applied this technology both for oncology, for detecting ctDNA, or circulating tumor DNA, in patients with cancer, as well as an organ transplant, where we use a donor-derived cell-free assay to identify early signs of organ rejection. And when we developed Signatera as a company, we really focused on three core use cases. The first being molecular residual disease assessment. So this is detecting ctDNA in patients with early stage disease to identify evidence of micrometastatic disease. Furthermore, using the assay in the surveillance setting in patients who've already finished definitive treatment to identify early signs of molecular recurrence. And then lastly, in treatment response monitoring, and this is using ctDNA as a very accurate measure of the molecular tumor burden in the patient to really track a patient's response as well as development of resistance to usually systemic therapy. Signatera is not an assay designed for asymptomatic cancer screening, so this is identifying patients with cancer before a histological diagnosis is made. And it's also not an assay that's really focused on cancer therapy selection. This is not an assay to identify actionable mutations to really select a particular therapy for a patient, which typically is reserved for patients with advanced or metastatic disease. The way the assay works, and really the way it is able to accurately detect very small levels of circulating tumor DNA, is that it's really the first commercially available tumor-informed ctDNA assay. The way the assay works is that we always start with a patient's tumor that's usually either available from an initial biopsy or from a surgical resection. Usually FFPE tissue is sent, and then the sequence, and we actually do whole exome sequencing to identify the full complement of somatic tumor-derived mutations in that patient. And then using a proprietary algorithm, we really select the clonal or truncal mutations in that patient's cancer. And these are mutations that really occurred very early in the tumor's evolution, and because of that are going to be present in all subsequent subclones in that patient's cancer. So even if a patient's tumor undergoes complex subclonal evolution in response to future lines of therapy, the clonal mutations will always be present in all of those subclones and will be a really great approximation of the molecular burden of disease in that patient. So after selecting the 16 most clonal mutations, we design a personalized or bespoke assay for each patient's tumor. And really by having this degree of personalization, we can really guarantee that every patient's tumor can have an assay with really high sensitivity and specificity to track that patient's molecular disease burden over time. And once the assay is designed, it becomes extremely fast and effective to really do serial monitoring. So it's not a test that just is done once. It really is a test that works best if it's repeated to better understand the dynamics of the patient's evolution and tumor burden over time. So again, I think here we also basically highlight the principle of clonality, where if you do not select clonal mutations or these subclonal or branch mutations, you can actually, by this omission, end up tracking subclones, which may not be representative of the overall molecular tumor burden in that patient. And really, the reason we've designed an assay with such high sensitivity is that in all of our prior studies, when we've looked at the concentration or the amount of circulating tumor DNA in patients with early stage disease, we've really found that more than half of patients with MRD positivity have circulating tumor DNA between the 0.01 and 0.1% variant allele frequency range. To put that in perspective, variant allele frequency is the proportion of tumor DNA compared to normal cell-free DNA. So really that's detecting down to 1 in 10,000 copies of circulating tumor DNA. And again, in this range, we see that more than 50% of MRD positive calls are made. And this is really regardless of the underlying histology, be that breast, colon, or lung cancer. And furthermore, patients with these low levels of MRD signal, they behave differently. These are the patients with less micrometastatic disease. And that's evident in that patients with these low-level MRD positive calls take much longer to recur. So we see that on average, these patients take upwards of 80 more days to recur without additional therapy, really suggesting that really these are the patients with low-level micrometastatic disease. And studies are ongoing to see if really these are the patients that may be most likely to benefit from adjuvant therapy. So we've now completed validation studies in 4 major cancer types. In colon cancer, with these data being published in JAMA Oncology, breast cancer, this was published in Clinical Cancer Research, lung cancer, and this was highlighted on the cover of Nature, and then bladder cancer, and this was published last year in JCO. And really, I think the striking thing is that clinically, really regardless of the underlying histology, in patients with early stage disease that's been treated with curative intent, for most of these cancers, that's either surgery or surgery plus minus adjuvant chemotherapy or sometimes radiotherapy. But regardless of the method, in patients who've been treated with curative intent, if we still detect circulating tumor DNA in those patients' plasma with Signatera, the chance of that patient going on to recur without additional therapy is close to, if not 100%, which really suggests that the assay has extremely high specificity for detecting micrometastatic disease. So unlike conventional clinical or pathological staging system that really try to estimate the probability of somebody having micrometastatic disease, the first time we can actually now measure the presence or absence of micrometastatic disease without really having to probabilistically estimate it. On the flip side, patients who are MRD negative by Signatera, patients who don't have ctDNA detected, especially if they don't have ctDNA detected on longitudinal monitoring over a period of time, these patients, shown on the green line, have an exceedingly low risk of recurrence, with most of these patients being cured of their disease. And again, this also makes sense. If we don't detect traces of circulating tumor DNA, which are approximations of the presence or absence of micrometastatic disease, these are the patients who are likely been cured with their definitive therapy. And the last thing to highlight is the average molecular lead time. And this is the period of time between detection of circulating tumor DNA or molecular recurrence to time of clinical or radiological recurrence. And this obviously depends on the aggressiveness of the underlying malignancy, but for tumors like colorectal cancer, ctDNA can be detected up to 8 to 9 months on average earlier than clinical or molecular clinical or radiological recurrence, which really provides this window of opportunity to identify recurrence earlier to possibly allow for surgical intervention for hopefully oligometastatic recurrence in these patients. So just kind of highlighting the structure of the JAMA Oncology study that we showed previously. So this was a study done with our collaborators at Aarhus University. This is a prospectively collected multi-centered study that was retrospectively analyzed, which enrolled 125 patients with stage 1 to 3 colorectal cancer that were treated with both surgery plus minus adjuvant chemotherapy. Over 700 plasma samples were analyzed, including samples from the pre-surgical, the MRD, or the post-surgical time period, as well as serial samples in the surveillance setting to identify molecular recurrence. As you can see, most of the patients in this study were stage 3 or higher risk patients. There was also some stage 2 patients as well. And really, we'll highlight the results in a little bit, but really on the back of the study, Signatera was recommended for a draft LCD coverage decision by Medicare for helping guide adjuvant treatment decisions in conjunction with clinical and pathological risk factors for patients with stage 2 and 3 colorectal cancer, as well as in the surveillance setting at the same frequency as CEA. And additionally, Signatera was the first MRD assay to secure FDA breakthrough status as a lab-developed test. And the way we think about MRD testing is really in 2 buckets, especially for most GI malignancies. The first being the MRD program, and this is MRD testing in the post-surgical period that extends into this adjuvant period, both for detection of micrometastatic disease as well as treatment response monitoring to actually better understand if patients are responding or not responding to their adjuvant treatment. And then additionally, in the surveillance setting, where patients have now finished their definitive therapy and are being surveilled for recurrence. And the schedule that we recommend was really the schedule that we've studied the most in our retrospective studies. And this includes testing for MRD in the post-surgical period. Typically, we recommend for the first test to occur between 2 and 4 weeks after surgery. We have seen that cell-free DNA or normal cell-free DNA levels can be markedly elevated in the post-surgical setting. Therefore, the sensitivity of most ctDNA assays are really impacted immediately after surgery. It takes around 2 weeks for cell-free DNA levels to normalize. So really because of that, we first recommend checking MRD immediately, kind of 2 weeks to 4 weeks after surgery, which really coincides very nicely with the first medical oncology visit. Additionally, we've seen improved performance by repeating the assay. So like I said previously, this assay is best used longitudinally. So we also recommend repeating a second test, usually 1 month later, especially if this patient is going to be considered for treatment de-escalation. This is to really confirm that MRD is absent in these individuals. And then lastly, we recommend testing kind of on every second cycle or every second month of adjuvant therapy. And we've seen that these are really the optimal time points for assessing either benefit or lack of benefit from adjuvant therapy, especially in MRD positive patients. So just highlighting some of the data from this study. The first is just the hazard ratios associated with the presence or absence of circulating tumor DNA. So here we show the hazard ratios of longitudinal MRD testing, MRD testing after finishing definitive treatment, as well as MRD testing in the post-surgical pre-adjuvant period. You can see that the hazard ratios associated with MRD positivity range from 7 to 43, really suggesting patients who are MRD positive are anywhere from 700 to 4,000 times more likely to recur if they're MRD positive at any of these time points. And just to compare this to kind of what some of the traditional clinical and pathological risk factors that are used to really guide adjuvant treatment decisions in these patients. For example, T4 versus T1 to 3 pathological stage. So, for stage 2 patients, T4 disease is considered very high risk. And sure enough, published literature suggested hazard ratios of a T4 tumor being somewhere around 1.5. So patients with T4 tumors are 50% more likely to recur. Similarly, for tumor grade, the hazard ratio is around 1.3. You're going to really see that the hazard ratios associated with ctDNA are really on an almost different scale. So much so when you do multivariate analysis and you include ctDNA status in a multivariate analysis with every known clinical and pathological risk factor, stage, grade, sidedness, molecular features, really the only feature that stands out as significant in such multivariate analysis is the patient's MRD status. And that makes sense because, again, all of these traditional clinical pathological risk factors are used to estimate, used to predict the probability of somebody having micrometastatic disease. Well, for the first time, using ultrasensitive MRD technologies like Signatera, we cannot necessarily just predict, we can actually just tell if somebody has micrometastatic disease present after surgery. So just zooming in, so what if we look at just the MRD positive patients immediately after surgery from a single time point or after definitive treatment? And we see that patients who are MRD positive after definitive treatment who do not receive additional therapy have almost a 100%, a 97% risk of recurrence with enough clinical follow-up. So again, this really suggests that if you have MRD positivity and you do not receive additional therapy, you will go on to recur with additional, with enough time. So I think when we first started in this field, there was some thinking that, well, gosh, maybe the immune system would clear some of this MRD signal. But really, regardless of the histology we've looked at, that does not appear the case. Anybody with MRD positivity who does not receive additional treatment with enough follow-up will recur. You could also ask the question, well, gosh, if somebody's MRD positive, it could be that these patients are going to have a bad prognosis regardless of what is done to them. So regardless if you treat them or you don't treat them, this is a very prognostic sign, but maybe not very predictive. But we see that that's really not the case. So for patients who are MRD positive but do receive additional treatment in the adjuvant setting, these patients still have a poor prognosis, but instead of having a close to 100% risk of recurrence, the risk of recurrence is only 70%. So there's a 30% absolute risk reduction for patients who are MRD positive but do receive adjuvant therapy. And if we think back to some of the pivotal adjuvant studies, like the Quasar study, the relative risk reduction of adjuvant therapy is predicted to be in the order of kind of 25 to 35%. So really what has been predicted from these studies, we can see play out by stratifying patients by MRD positivity. Now, if we focus on patients who are MRD negative after surgery, so from a single time point, if you're MRD negative in this study, which again was primarily composed of stage 3 patients, the risk of recurrence drops to just 12%. So you're going from patients who typically would have a recurrence risk of 25 to 35%, and you drop it down to just 12%. And this is comparable to patients with stage 1 disease, for which we do not typically recommend adjuvant chemotherapy. Furthermore, by doing serial testing, if somebody is negative on serial monitoring with Signatera, the risk of recurrence for patients who stay MRD negative drops to just 3%. So that starts approaching zero. So, how can we use this information to better inform adjuvant treatment decisions in certain patients where this decision may be difficult using traditional clinical and pathological risk assessment? So just highlighting a few case studies. So some of these case studies have come from our collaborators. So for example, rectal cancer. So in rectal cancer, the traditional treatment has been chemoradiation followed by surgery and then plus minus adjuvant therapy. Currently with the coronavirus outbreak, surgeries have been pushed off and there's been increased interest in TNT or total neoadjuvant therapy, which is a combination of both adjuvant like chemotherapy, like FOLFOX, for example, given before surgery, then followed by chemoradiation, and then patients are assessed for either surgery, depending on the presence of residual disease, or based on sometimes patient-physician preference, possibly kind of a watchful waiting approach. So in this case, we want to highlight a 69-year-old female with a clinically T4N2 tumor of the rectum, MMR stable, who was initially started on addiction chemotherapy with FOLFOX with plan for TNT. And really here the question was, well, can we better understand if the patient is benefiting from chemotherapy earlier? So could we use an MRD assay for treatment response monitoring? And here we show actually the results of the Signatera assay. So this patient initially started as ctDNA positive, as you can see on the report on the right, and this was before treatment was initiated. And then you can see that after just 3 cycles of FOLFOX, the ctDNA levels have dropped over 90%. It really does suggest that this patient's tumor has been benefiting from their chemotherapy. There are patients who, when you track ctDNA, who are on neoadjuvant therapy, you can see that the ctDNA just keeps going up despite their chemotherapy, which really suggests that these patients may not be benefiting from this treatment. And then based on clinical and radiological assessment, these patients may be evaluated for treatment non-response and may be pushed to surgical salvage earlier on. So then the question was, well, gosh, so if we continue therapy in this patient, would this patient achieve a deep MRD negativity? So a repeat test was sent, and you can see that after completing the FOLFOX treatment, this patient actually became MRD negative, so achieved MRD negativity with an ultrasensitive test, really suggesting that this patient is benefiting very, very well from this type of treatment approach. So here the plan is to continue MRD monitoring. The patient has shown interest, for example, in non-surgical approaches. So how can we think about ctDNA when we think about helping support especially adjuvant treatment decisions? Well, I think as we've shown with the data, patients who are MRD positive are extremely high risk for recurrence. And these patients really should be thought of as high risk regardless of their underlying clinical or pathological traditional risk factors. So especially in patients where the adjuvant treatment decision may be difficult based on traditional risk factors, assessing MRD status, especially if it's positive, can be very helpful to really make a confident decision about who should or should not receive adjuvant therapy. Similarly, patients who are MRD negative, so from just a single time point, we know that these patients' risk of recurrence is markedly reduced, so to less than 12%, comparable to patients with stage 1 disease. So again, this may be very helpful, especially for patients who may be less fit, who may be at high risk for treatment-related morbidity, or patients who may be unable to come into the infusion center during this outbreak to really help better assess their risk, especially if treatment de-escalation is being already clinically considered. So here we just highlight the schedule for surveillance testing that's been proposed by Medicare for Signatera. And the proposed schedule follows that which has been typically used for CA. So that's every 3 months for the first 2 years, and then every 6 months from year 2 to 5. And from our JM Oncology paper, just wanted to highlight some of the results that really have shown how much earlier you can detect molecular than clinical or radiological recurrence. So on the figure on the left, you can see the green dots represent time to radiological recurrence, while the purple dots represent time to molecular recurrence. And you can see that on average, molecular recurrence happens around 9 months earlier than radiological recurrence. And furthermore, the mean time to molecular recurrence is just 5 months after surgery. So in the majority of these patients, you can detect residual molecular disease very, very quickly after surgery. And this can still be during the period where some intervention may be applicable to these patients. And on the right, you can actually see what happens to ctDNA in the absence of treatment. So patients who are undergoing surveillance without any intervention, you can see that each line is a patient, and you can see just how ctDNA kind of keeps going up. You can also almost see how the tumor is growing in the background until you get to the time of radiological recurrence. So really having this information can be very helpful to identify patients in an earlier stage when they may be still candidates for curative oligometastatic resection. Furthermore, patients who are MRD negative, as we've shown, are very unlikely to recur. So that may be helpful, especially in patients where imaging or follow-up visits are being delayed. So this is just data showing that patients who are MRD positive after finishing adjuvant in the surveillance setting, if they become positive without additional therapy, the risk of recurrence is 100%. And then the sensitivity and specificity of Signatera compared to CA is displayed here. And I think the most important thing is to just basically highlight the specificity. So the specificity of the assay is close to 100%. So any patient who is MRD positive, that really means that patient has residual disease. So unlike CA, ctDNA assays like Signatera are not falsely elevated because of, for example, liver dysfunction, alcohol intake, smoking, etc., which are kind of common issues with traditional CA testing. So I also want to just highlight one case example during surveillance to show how this assay is being currently used. So this is a patient who was diagnosed with T3N1 left-sided colon adenocarcinoma, microsatellite stable. This patient initially was treated with 3 months of Zelox in the adjuvant setting. Unfortunately, during routine surveillance imaging, this patient was found to have an enlarging pulmonary nodule as displayed on the CT image on the right. Shortly after, an attempt was made for a CT-guided biopsy of this lesion. However, this unfortunately resulted in pneumothorax for the patient, and the biopsy did not show evidence of malignancy. And there was some concern that insufficient sampling was done given this periprocedural complication. So the patient was very hesitant about a repeat biopsy, despite the concerning appearing nature of this lesion on the CT scan. And really asked, well, gosh, could we, for example, check MRD to better understand is this likely to be a recurrent tumor, or maybe this is, for example, an inflammatory process. So Signatera was ordered in this setting to better evaluate the presence of circulating tumor DNA. And in this case, Signatera came back positive for ctDNA. And this really helped to drive the decision to do a repeat biopsy. And the repeat biopsy showed recurrent colorectal adenocarcinoma with features similar to the initial primary. This then led to the patient being able to undergo mastectomy earlier this year. And then the patient was actually evaluated for possible kind of mop-up adjuvant chemotherapy. But there was also concern that kind of given the immune suppressive nature of this type of treatment during the outbreak, could this patient be actually watchfully observed? So here Signatera was ordered in the MRD setting after the surgical procedure to better evaluate presence or absence of ctDNA. And here the patient's ctDNA result on the second test you can see came back negative. So the patient did not have any evidence of ctDNA. And again, while this is not completely definitive that the patient has no tumor, again, that's only likely if the patient continues to stay MRD negative. Really, in this patient where the decision about additional systemic therapy was already borderline, this was helpful for the clinician to make the decision for ongoing watchful waiting and monitoring of Signatera going forward. So the way we typically then recommend ordering our assay in the perioperative setting is to do, again, the initial test at the first medical oncology visit 2 to 4 weeks after surgery, then repeating the test in 1 month, especially if treatment de-escalation is being considered, and then at months 2 and 4, usually during adjuvant therapy if that's prescribed, to better understand treatment response or lack thereof. And then in surveillance setting, again, we recommend MRD testing using the same frequency as you would for CEA. Again, this is a sample test report. So we quantify both the presence and absence of ctDNA, and we report it out in absolute terms in immune tumor molecules per ml. That's the MTM per ml. We find that this measure is much better than that, especially for monitoring ctDNA over time. Just because this is an absolute measure of circulating tumor DNA, it is not impacted by the fraction of normal cell-free DNA, which can sometimes change fairly significantly with underlying health conditions, for example, presence or absence of surgery, or, for example, systemic treatment with chemotherapy, which can alter the quantification of ctDNA through measures like that. So with this, I really wanted to also introduce the Signatera GI Expanded Access Program. So during this unprecedented time, you really want to make MRD testing available broadly for patients, not just with colorectal cancer, but with GI cancers in general. And really to accomplish that, we've now introduced this GI Expanded Access Program, where patients with any stage or type of gastrointestinal malignancies are eligible. So not just patients with colorectal cancer. So we have more information on our website. You can also email us at this Signatera ACC email to learn more about this program. We've also really been working to expand access to our mobile phlebotomy offerings to really allow for patients to receive testing at the comfort of their home. So not even having to come in to get their blood drawn, but also being able to send a mobile phlebotomist to their house on physician request to allow home-based draws for Signatera testing, which can be really helpful in the setting of surveillance visits that may be canceled or pushed back given resource constraints at this time. And currently this program is going to be available until at least the end of July, but we're always evaluating if it makes sense to expand this program beyond that. And really also the goal here is that through this compassionate care program, really the goal is to minimize any out-of-pocket expense to the patients, where the vast majority of patients on this program end up owing $0. And then how does remote monitoring work? Well, we've now introduced an online ordering portal where all of the ordering can happen electronically. And this also allows for ordering of home phlebotomy services, where if ordered, patients first of all receive a call, have a kit shipped to their house, and our coordinator really sets up the whole mobile phlebotomy experience, finds the optimal date and time, arranges a mobile phlebotomist to come and collect the patient's plasma for Signatera. These results are then delivered to the physician for interpretation. Usually for the first test within 3 weeks of receipt of tissue. For all other subsequent tests, the turnaround time is faster than 1 week. And then just to highlight the provider portal, so this is something that we've recently launched to really allow for paperless ordering as well as tracking of results. This is completely electronic and then again allows both for viewing of all outstanding orders, all completed orders, and allow for online ordering and setting up a mobile phlebotomy for your patients. This is a snapshot of the portal, so you can see both the patients, the results, and if the test is in progress, or the results are ready for viewing. And again, we've really also been working to make this process of ordering as easy as possible. So we have really developed our customer care team to make the process as smooth and as painless as possible. This is the scope of our mobile phlebotomy offering. So you can see that we offer mobile phlebotomy in pretty much all states. And with that, I just also wanted to highlight a patient-centric webinar we're holding next week. These are the presenters. And with that, I thank everybody for your attention, and we have 20 minutes to take some questions.
Okay, great. We do have some questions, so we'll dig right in here. First question is, are there any of the mutations you select driver mutations?
Yeah, that's a great question. So with a tumor-informed method, we really select clonal mutations. We don't put any emphasis on the particular type of mutation, but because most driver mutations are clonal in nature, some of the mutations we select turn out to be driver mutations.
All right. Next question is, do you find any shared variants or mutations among patients with the same tumor type?
That's a great question. So the reason we do Signatera as a tumor-informed assay is that even despite the fact that there are certain hotspot mutations that are frequently shared between the same type of tumor, beyond just a few of these mutations, there's actually very few other shared mutations. So the tail of the types of mutations is a very long tail. So if we look even within a particular histology, the percentage of shared mutations between two patients is less than 1%. And that really kind of highlights the need for an individualized or bespoke assay for ultrasensitive detection of ctDNA in these patients.
Okay, next question is about mobile phlebotomy. So the phlebotomists arrive at the patient's home now during quarantine, is that correct?
Yes, so the phlebotomists come. The phlebotomists are frequently tested to make sure that they don't have any symptoms that would be suggestive of COVID. They come in with PPE and are able to draw the plasma for Signatera testing during this COVID outbreak. And that program is moving forward. There's been no issues getting access to mobile phlebotomy at this time.
Okay, kind of a related question. What type of tissue do you need? What are the requirements for blood collection and blood volume?
Yeah, that's a great question. So the amount of tissue that's needed for designing Signatera is very similar to the amount of tissue needed for other CGP-like tests that you may be familiar with for assessing actionable mutations in tissue. So that's typically 5 to 10 slides, between 5 and 10 microns thick, or a block that we can section and then ship the remaining material back to the pathology lab. In terms of the volume of plasma, so for the first time point, we draw 2 Streck tubes as well as 1 EDTA tube to both evaluate for presence or absence of ctDNA as well as to design the initial test. All subsequent tests require 2 Streck tubes worth of blood, and that's a draw between usually 15 to 20 mLs total volume.
Okay, next question here. If you have multiple recurrence, which tumor sample should be used, primary or recurring tumors?
That's a great question. So because this is a clonal-based personalized assay, and clonal mutations, by definition, should be present both in the primary and all recurrences subsequent to that, really we don't see any performance changes based on the tumor type. So Signatera can be designed from the initial diagnostic biopsy, from the surgical resection, or even from recurrence. So for example, a patient who may have recurred in the liver and had an oligometastatic resection, that tissue is also able to be used to design the assay. So again, there's no preference for the type of tissue, assuming there is enough tissue to design the assay. So for example, for small biopsies, there may be issues with tissue quantity. So that's kind of just the only thing we suggest keeping in mind.
All right, excellent. Next question. You may have touched on this, but there's a follow-up here. How long after surgery can testing be done?
Yeah, that's a good question. So we do not recommend testing too close to surgery. So for example, testing a day after surgery is unlikely to provide a good result just because of the high amounts of inflammation and high background rates of cell-free DNA. That said, for testing that's done immediately after surgery, for example, like a week, a positive result still means that the patient has MRD, but it's mostly, again, the sensitivity of the test that's affected. We see that these background cell-free DNA levels normalize around 2 weeks after surgery. So that's why we think the optimal period for testing for MRD is between 2 weeks and usually around 4 to 6 weeks after surgery. And the reason for that is that this allows enough time for the test to result to help inform the adjuvant treatment decision, where there is data that suggests that delaying starting adjuvant therapy beyond kind of 6 to 8 to 10 weeks, depending on the study you look at, may have poor outcomes for these patients.
Okay, next question. I'll give it a try here. For patients with disease recurrence detected by Signatera, how many of these patients had curable recurrence with oligomets?
Yeah, that's a great question. So in our initial validation study, since these were prospectively collected but retrospectively analyzed, it's hard to say because the results of the test were not able to be acted upon. But in our clinical testing experience, some of which will be presented this year at ASCO, we definitely do see that patients who become MRD positive, leading to a physician to usually escalate the type of imaging, either the frequency or the modality, we definitely do see patients being detected at an oligometastatic stage. I can't comment on the exact rates, but we definitely do see that trend. Also, I think if interested, we've recently also published a case report in JCO Precision Oncology, basically showing how Signatera was able to capture an oligometastatic recurrence in a patient with esophageal cancer. So that may be interesting to review as well.
Okay, next question. I'll give this one a try as well. Is there any data or ongoing study to look at patients with metastatic CRC who have had a clinical CR to see if they can stop treatment if ctDNA is negative?
So there are no prospective studies that are looking at this question. We do have data from our clinical testing experience about MRD rates in the setting of patients with near CR or CRs in the metastatic setting. Some of this data, again, will be presented at ASCO, where we basically show some data about what are the outcomes of patients who are or able to achieve MRD negativity in the metastatic setting. So again, I think this data will be presented very soon.
Okay, great. Looks like we have just a couple more here. Can you talk more about when the tissue block is needed, or is this a blood test only?
So Signatera is a tumor-informed assay, so we do need tissue to design the assay. Without tissue, we cannot identify the tumor-specific somatic variants for which we designed the personalized assay. There are some tumor-naive assays on the market or being developed, but really the problem there is actually identifying enough somatic variants to track in parallel. Really, the power of a tumor-informed approach is that we can always identify 16 mutations to track for each patient's tumor. And when we're looking for low levels of circulating tumor DNA, to put this in perspective, a tube of blood, a 10 cc tube of blood, will have around 10,000 haplogenomic equivalents of normal cell-free DNA. And I think, as we mentioned earlier in the webinar, sometimes we really need to be able to detect down to 0.01% BAF. So that's equivalent to detecting one haplogenomic equivalent in the background of 10,000 in a tube of blood. And at those low levels, just having a molecule to detect sometimes is a discrete probability. So by being able to multiplex 16 variants together, we really have kind of these multiple shots on goal to detect low levels of circulating tumor DNA. And really the only way we can get enough shots on goal is by doing kind of a tumor-informed approach. So it's a long answer, but basically, yes, we do need tissue. Without tissue, we cannot design the assay in its current form.
Okay, great. Next question is, do you report actionable mutations from the ctDNA results?
So we do not report the actionable mutations because a lot of the mutations we track are very benign mutations that just occurred early in the tumor's evolution and may not have any clinical significance. So Signatera focuses on the most clonal or truncal mutations. As we mentioned earlier, some of them are hotspot mutations, but many of these mutations have no clinical relevance and just occurred very early in the tumor's evolution. So they're great molecular markers of the amount of tumor, the presence or absence of residual tumor in that patient, but really don't have a clinical significance. Since we do sequence the initial tumor, and we do clinical grade whole exome sequencing of it, tumor normal, that is data that we are thinking about in the future, actually annotating and making the whole exome sequencing report available clinically. But that's not something currently that we're offering beyond our research collaborations.
Okay, great. Last question here. Is Signatera only applicable to solid tumors, or can it be used for hematologic malignancies as well?
Great question. So currently the assay is validated for solid tumors. That includes non-Hodgkin's lymphomas, so diffuse large B-cell and follicular lymphoma. For other hematologic malignancies, especially diseases that have a circulating component, the assay is currently not validated and it's not recommended to be used in those settings. So diseases like AML, MDS, we would not recommend using Signatera currently. However, we've seen on a research basis a very, very good performance of the assay for B-cell malignancies, where we're doing some additional validation studies to see if we can expand the indication to diseases like CLL as well as multiple myeloma in the future.
Okay, great. On behalf of our audience, I want to thank Dr. Aleshin for his presentation today. Now, if we did have questions that maybe have overlapped with the ones we covered or we did not have time for today, we'll forward those on to Natera for individual follow-up. At this time, we will end the webinar, and you may now disconnect. Thank you very much.